Last time we talked about hypothyroidism in pregnancy, but an overactive thyroid in pregnancy makes for many different issues. There's different causes, there's different treatments, and there are risks associated with it if it's not managed correctly. Here's what you need to know. Let me first start off by talking about the types of hyperthyroidism in pregnancy. So there's essentially three or so different types of hyperthyroidism in pregnancy. The most common situation where there are abnormal thyroid function tests are a situation where there is an increased hormone called HCG, which is associated with pregnancy, and all mothers who are pregnant have elevations in HCG. Well, HCG cross reacts with the hormone TSH and then can be associated with a suppression of that hormone TSH, which then would indicate to a physician, an OBGYN, that the woman might have hyperthyroidism. But oftentimes in those situations, it's just the artifactual nature of the TSH and the HCG cross-reacting. And in that case, that's really not a situation of hyperthyroidism, but needs to be evaluated to make sure that there isn't hyperthyroidism. And the way to do that then is to do the blood tests that are associated with hyperthyroidism, the free T4 and the total T3, which in most cases are normal. So that's one of the things that we need to, that can fool the OBGYN and the mother, that they may have hyperthyroidism, but in fact, that's an artifact. The other condition is a condition that we call gestational hyperthyroidism, where the woman will have a TSH, which is suppressed, maybe a slightly high T4. And this is because they've had this significant amount of nausea, vomiting, and associated symptoms. And oftentimes those patients have been hospitalized, are unable to eat, they lose weight, they have a lot of situations associated with hyperthyroidism. But what happens is that usually that after the first trimester, those symptoms of nausea, vomiting, and so forth get better, and the thyroid levels return to normal. So they've, again, never really had true hyperthyroidism, but they've had this gestational transient hyperthyroidism as a result of the elevations in HCG. So those are the probably most common situations in women who are pregnant. Then there is hyperthyroidism that is associated with Graves' disease, which is the autoimmune disease in pregnancy. And some of the patients have had previous Graves' disease. That is, they've been known to have hyperthyroidism and then gotten pregnant. Or some of them haven't been known to have hyperthyroidism, gotten pregnant, gone to the physician, had blood tests, and they have hyperthyroidism and pregnancy. And the question in those cases is, what do you do about that? And there's the evaluations of hyperthyroidism in pregnancy only can be laboratory testing. We don't do another diagnostic test that we call a radioactive iodine scan, because the radioactive iodine scan would be contraindicated in a pregnant woman. So it's blood testing and physical examination, and then the determination of the level of hyperthyroidism. So again, in pregnancy, we always have to manage the risks of the medication that might be utilized for hyperthyroidism in pregnancy or Graves' disease in pregnancy versus the benefits of it to the mother and the unborn infant. And so in that case, there's a way to determine that. And that symptoms is one of the things, the levels of the thyroid hormone is another. And actually, hyperthyroidism in pregnancy sometimes gets better as the pregnancy goes along. So there's a fine line as to whether or not a patient who has hyperthyroidism in pregnancy will get treated with one of the anti-thyroid medications. And that really is determined by the clinical criteria, meaning how bothered, how symptomatic the woman is at the time of the pregnancy, and the risks, therefore, to the unborn infant. So there are conditions where there are crossover from the woman who has hyperthyroidism or even has had hyperthyroidism in the past and is not clinically hyperthyroid or not biochemically hyperthyroid at the time of the pregnancy or in this pregnancy can pass through the placenta to the unborn infant. And so we typically will measure a level of that antibody in the woman, usually within the second trimester, to see if there's any elevation of those antibodies. If not, then we are clear. And if so, we would need to monitor the baby, at least to some extent, tell the OBGYN and the maternal fetal medicine physician that there may be some signs and symptoms of hyperthyroidism in the infant. This is a very rare condition. Can't say that I've actually seen it in my practice of over 35 years, but it does happen. So an infant that was in the second or third trimester with fast heart rate or something like that through a monitoring by ultrasound might be a concerning feature, but this is very rare. And I would say not usually something that we have high clinical suspicion for. So as we talked about in pregnancy, oftentimes the woman may not need antithyroid drugs or maybe a very low dosage. We try to minimize the dosage of antithyroid drugs. And so there's this general phenomenon that autoimmune diseases tend to do better during pregnancy. It's true for diseases such as rheumatoid arthritis or ulcerative colitis, other autoimmune diseases, particularly with Graves' disease, another autoimmune disease. But after pregnancy, there is also sometimes a rebound effect, and there are situations where the hyperthyroidism becomes more significant postpartum, and we will need to be more aggressive with treatment. At that point, that becomes sometimes an issue with people who are breastfeeding, although this has been looked at, the amount of medication that is transferred through the breast milk is minimal in patients who are on treatment for hyperthyroidism with the antithyroid drugs. So it is really important when a woman is pregnant and has hyperthyroidism to be managed with the OBGYN because these conditions have significant consequences for the infant and for the mother. And it is important to maintain a very reasonable level of thyroid function in the mother during the pregnancy and then particularly also postpartum. And so management with a endocrinologist alongside the OBGYN is always necessary in patients who have Graves' disease in pregnancy or hyperthyroidism, which is being treated during the pregnancy. And anytime you need help with hyperthyroidism in pregnancy, I'm certainly very interested in this, love to take care of women who are pregnant in the sense that I feel like I'm really making a difference in their baby and their lives, and hopefully will have a great outcome.